Thank you and good morning. Catherine Georges, I have to say a very special thank you to you wherever you went, I know you're here, for reminding us that logic doesn't move anything. The fact that it's just on the face of it irrational that we have this situation, and that we have this situation decades after Medicare was first enacted. On the face of it, it makes no sense. It is totally illogical, and yes, I would mark down a student who tried to make the argument that this is rational. But logic doesn't move policy. I really appreciate that the Santa Fe group has invited Meg and me to share our experience with you. The situation in 1997 regarding kids was identical, absolutely identical to what we've heard yesterday and today. The arguments were the same, the findings were the same, the disparities were the same, the problem was the same, and an opportunity presented itself that we capitalized upon. I want to acknowledge all the work that has already been done. I learned a great deal. I live at the other end of the age spectrum as a pediatric dentist. But I will share with you that my heart was long ago, and I mean long ago, the year was 1975, really with the elder population. Having completed a GPR out of dental school, I met Lieutenant Colonel Plank on my first day in the United States Army Dental Corps, and he asked me, he said, we have 135 dentists on this post. What kind of dentistry would you like to do? And I said, well, I'm really interested in geriatric dentistry. And he paused and he said, we don't have any old people. And then following his logic, his own logic, he said, but anybody willing to treat old people would be willing to treat kids. So we'll put you in pediatric dentistry. Now, I had spent all my years of dental school and my GPR avoiding any child under the age of 16. So there I was, sitting there in a clinic full of short people, trying to figure out exactly what to do. And thank goodness there was a very sympathetic dental assistant who taught me what I needed to know. And I want to recognize that the world we work in is, in a policy sense, different than the world that you're seeking to influence, because Medicare is a unified federal policy, whereas Medicaid is 51 different policies, and then we can add in Puerto Rico with its unusual program and others. So it's just a hodgepodge of different policies. So there are real differences between Medicaid and CHIP, the Affordable Care Act, and Medicare. But nonetheless, I think we have some lessons learned. Now, the way we're going to set this up today, I'm going to give you a little history of how we got to where we are. I'm then going to show you what we have accomplished, and then Meg is going to describe the secret sauce and tell you how we got things done. And yeah, it'll be good to put the slides up at some time. I have a few more things to give as introduction here, though. I want to also not fail to recognize the tremendous work that Ron Inge and Victoria Rodriguez-Minowitz have done to make today and yesterday so valuable. I think it's time to acknowledge all that they have done. So if logic doesn't carry the day, then what might? For one thing, you certainly, and you've been working on this throughout the last 2 days, and you've been working on it for months and months as well, is communication. You've got to be able to tell your story. You've got to be able to really get your story into the minds and the hearts of the people you're trying to influence, whether those are legislators or regulators or partners or interest groups, the press. You can't have a coalition that cares unless people get it. And so you have to be able to communicate. So with any effort to communicate, you need to know how they think. You need to know what they know. You need to know what they care about. You need to know what opportunities they have and what opportunities they don't have, so you don't wear yourself out going in the wrong doors. You need to know what actions they're able to take. You need to know what makes them take action and who makes them take action and how they are influenced and who influences them and what makes them decide whether or not to prioritize this. Because if there's one thing we know about policymakers, that is that their plates are overflowing. There is more than enough interest by dozens, scores, hundreds of groups like this that are all asking for something, and every politician wants to say yes to everybody because they want to get reelected. And their plates are so full that there is no way that they can be your champion unless you somehow are able to communicate to them the significance of what you're trying to do. So go back 22 years, 1997. What did I set out to do after a year on the Hill as a health legislative aide to the Senate Minority Leader, Tom Daschle? I set out to establish my concern, pediatric oral health, as a public policy issue, as a bona fide public policy issue. So I had to find a frame for it. Well, was it foreign or domestic? Okay, it was domestic. Was it a social issue? Yes, it's a social welfare issue. Was it a health issue within that nest of social welfare? Yes. Was it a pediatric health issue? Yes. And then it was secondarily, tertiarily, quaternarily, it was way down the list that it was a dental issue. Most of all was the critical need to talk about consequence. If there was no consequence, there's no reason, there's no problem if there's no consequence. And the consequences were framed in terms of learning and growth and development and individual success and economic well-being and military readiness, but not as a dental issue. If I came in talking dental, I would have walked out talking dental, and there would have been absolutely no movement. So how did we find out how to talk to people? Well, we talked to people. And who did we talk to? We talked to Hill staff. We said, how do you see our issue? How do you see the concern that we have? How does your boss think about this issue? Where would your boss park this issue? We talked to everybody we could get our hands on in the federal government, every agency that had a dental person. And we said to those people, what have you been trying to do? What's working for you? What's not? What is the goal? How do you frame this? How do you see this? We talked to advocates, not dental advocates. We talked to child advocates and health advocates. We talked to pharmacists and nurses and anybody who walked into our office, which I'm pleased to say was one chair, one desk, one phone, and me. And that was at the American Academy of Pediatrics, Washington office. And so there we were in 1997, had a logo donated to us from the American Dental Education Association, ADEA, fresh stationery, still a little tacky, a freshly secured 501c3 designation, and an idea, a mission, a goal, a commitment, and time. We partnered very closely with other people who were facing the same kind of issue. Who faced the issue most closely to us? The mental health champions. We became known as the ENTLs, the dentals and the mentals, working together to try to figure out this puzzle. And we studied, we did our homework. We studied legislation, we studied regulation, we studied rules, we studied guidance. We became wonks. We got down deep in the weeds because the people who we needed to help us live in the weeds, so we needed to be able to work with them and they needed to be able to work with us by sharing language. All right, skip ahead to 2006. Now we had our own office, we had a refined mission statement, we had a clarified vision, we had a small but passionate staff, we had some legislative successes, we had some strong partnerships and collaborative relationships, we had a recognized name and brand. And then came Meg Booth. So Meg came to interview for a policy position, and we recognized instantly that Meg got it when she talked about how critical to CDHP it would be to further develop relationships, to become the reliable go-to source of information, to be the true inside the beltway wonks on the issue, and to be ready, always ready to capitalize on any opportunity. She featured for us the idea of slow and steady, persistent, resilient commitment to cause. She interviewed us to find out whether we were those people. And I'm pleased to say that she not only took the job then, but working through what became a larger organization all the way up to 9? Did we ever get to 9 people? Maybe. Became the executive director of the position that she now has. We intentionally did not become a membership organization. We didn't want to have to work our way through an organizational policy development. We wanted to be facile and quick and ready and responsive. We developed a supportive board of people who were in the world that we were trying to influence, by and large not dental people. All right, now skip to today. We have some remarkable successes, and I want to thank Marco for his shout out where he showed that things have improved dramatically for kids. But the work is never, ever, never, ever done. We heard yesterday a clear statement that getting the benefit is the first step. Then there's more work and more work to be done. And 22 years later, what I thought was going to be a 2 or 3 or 4 or 5 year effort, and then realized that CHIP was going to be reauthorized in 10 years, I said, okay, it's a 10-year effort. Now it's 22 years later, and as you'll see from our formal presentation, we still have much to do. So as you seek to secure a Medicare benefit, you need to be as focused on a singular problem as we were at that time. I heard yesterday a variety of problems discussed: coverage, benefits, disparities, access, utilization, cost, workforce. And that's only a partial list of what I heard yesterday. When you present complexity to a complex system, they have no way of dealing with it. You have to present simplicity to a complex organization. And so you need to have a really clearly defined problem, clearly defined goal, and you need to bite off a piece that's attainable. So to our presentation. I'll discuss what we've done, Meg will discuss how we've done it. There must be a, would this be it? Green button. I'm totally colorblind. Why anybody would choose green and red for a colorblind person, I have no idea. The big button, that's the thing. Okay, the big green button. So, what did we set out to do? What did we accomplish? And as importantly, what have we not accomplished? How did we accomplish the objectives, and what lessons may there be for you in your work? A little more history. This time, not history of CDHP, this time history of what's gone on in the United States Congress. 1965, Lyndon Johnson, Great Society. Lyndon Johnson wanted to have a program that covered kids separately, older adults separately, and the working poor separately. Medicare, kid care, and Medicaid. Medicare and kid care were to be universal. They were not to be just for the poor. But much was going on in 1965, and what he was able to secure was Medicare, universal health coverage for seniors, and Medicaid that included both poor children and poor working age adults. And dental was sort of implied as optional. That was 1965. 1967, just 2 years later, child advocates came to the Hill and said, you know what, you got a pretty good program there in Medicaid, but it doesn't make any sense for kids. Kids are not junior adults. They have different issues and different problems, and so what you need to do is have a special benefit for kids. And thus came EPSDT, the most sacred letters to any of us who work in pediatric policy, early and periodic screening, diagnosis, and treatment, which says, get this for a benefit. Can you imagine your insurance having a benefit that says, anything your healthcare provider says you need, you got? And that's what EPSDT says. And therefore, recognizing that kids had mouths and mouths had teeth, dental care was covered implicitly. It became explicitly covered in 1985 or 1987 through one of the Budget Reconciliation Acts. But throughout this time, adult dental coverage remained optional. I think one of the most serious problems those who are working on Medicare face is the lack of a uniform Medicaid benefit for working age adults. Because what you have is from age 21 to age 65, a growing dental need. And then people show up in Medicare, and if there's a Medicare benefit, you're going to have all this backlog of unattended oral disease with these growing disparities both in use of services, as Marco told us, and oral health status. So if you want to turn off the tap to the problem, you really need to address the adult side of Medicaid as aggressively as the Medicare benefit. Okay, what more happened for kids? 1997, S-CHIP, a compromise legislation. Dental was made optional. Why optional? Well, that's a story we'll get to in a minute. CHIP reauthorization was supposed to be 10 years later. It took a little while longer because we had to wait for a president who would sign it. And now a mandate. And how do we get the mandate? Well, for 10 years, from 1997 to 2007, CDHP worked with national organizations of state policymakers, legislators, governors, Medicaid officials, public health officials, and with child advocates, so that by time 2007 came along, every state had elected the optional dental benefit. Then we could go to Congress and say, we know you hate mandates. We know you don't want another mandate. We're not asking for a mandate. No mandate. But since every state has it, and we want to see it sustained, and you want to see it sustained, why don't you just put it in the law? Okay, so that's how the mandate came to be in the CHIP legislation. At the same time, ACA, the Patient Protection and Affordable Care Act, was bubbling up, and the securing of that benefit. So this is a fundamental problem for Medicare. On the one side, you see a uniform color across all states. Every state has a comprehensive dental benefit for kids. On the other side, you see a hodgepodge of different Medicaid eligibilities, different Medicaid coverage for adults in those states. And so without a uniform Medicaid benefit, all we have is tremendous disparities growing, and growing more so in states with little coverage. So what do we set out to do? Well, as I mentioned, S-CHIP was enacted, and there was only the option for states. Now, this option didn't make any sense to me as a pediatric dentist who'd come out directly out of practice for this fellowship. It was as irrational as what Dr. Georges just shared with us about the lack of a Medicare dental benefit. And yet that was the situation. So every policy, and therefore every piece of legislation, begins with a problem. The problem that we were founded to address was oral health inequities. Now, oral health inequities includes that whole laundry list of all the issues that I mentioned before that I heard yesterday from various speakers. So we had to start with a very specific policy. And the policy we sought was dental coverage for all children to assure that they had financial access to care. And we framed it as a disparity between medical coverage and dental coverage. We didn't frame it as a disparity of oral health or dental visits. We framed it as a disparity between medical and dental coverage. And we said, kids have only one body. They have their medical coverage in spades, but they're short on their dental coverage. And our mission was a little broader. We sought pediatric coverage mandate in any kind of health insurance program that was going to move. So, 22 years of coverage, what are the policy successes? We've worked to retain the Medicaid EPSDT robust benefit so far, but we never stop working on that, never ever stop working on that. What was mentioned just a moment ago about changes in Kentucky, as efforts are made to cut the rolls of Medicaid beneficiaries, well, that cuts the rolls for kids as well. address S-CHIP's lack of a dental mandate, and secure dental coverage in the private marketplace through the ACA. So here are just some examples of the work that we do to maintain a focus on keeping the Medicaid benefit. Here is the down deep in the weeds. I know you can't read it, but even if you could read it, it wouldn't make any sense because this is a different language. This is legislative language. And this is how we were able to secure the dental mandate in CHIP. ACA, by the time ACA came along, we had become the nonpartisan, non-dentist group, child and family advocacy entity in Washington that policymakers and their staffs could turn to for objective reflection on what others were asking for or not asking for. We therefore set out to get a full dental benefit for every age. And that is what we sought. And we sought it aggressively. And everybody we talked to, we said, this is the opportunity to right the wrong. This is the opportunity to be rational. This is the opportunity to recognize that all those good things you've done for kids disappear when they turn 21. And so let's go for it. Let's do the adults and the seniors all at the same time. That's the response we got. So we backed off and we said, kids are vulnerable, but kids with special needs, kids with disabilities, when they become older than 21, they don't give up their disabilities. They still have the same disabilities. So how about if we cover adults and seniors with disabilities? They're vulnerable. They're just like kids. Okay, the next try, pregnant women. Everybody agreed that kids came from pregnant women. So here was our chance to say, kids are part of two generation. They're part of families. They come from the mothers. The mother's oral health influences the kid's oral health. And so we made that argument. Okay, then we went to kids. And kids we succeeded with because there was already all this momentum. Kids were covered in Medicare. Kids were covered in Medicaid, EPSDT. Kids were covered in S-CHIP, optional, but then mandated in CHIP. They now had the opportunity to just keep the same thing going, and so we were able to secure that. What happened? Well, Marco gave you the preview. I'm going to give you just a little bit more detail. The percentage of children and teens, so it's up to age 21, with no dental coverage dropped from 27% to 10%, and hopefully it's continuing to drop a little further. Where did they get this coverage? It came from Medicaid, CHIP, and in the ACA, some families were identified as being Medicaid eligible, so the kids could pick up Medicaid, and some families were able to secure the health benefit from the essential health benefit. I want to rewind for a minute and tell you, it's never simple. It's always more complicated than it looks, and you're always learning. How many of you are familiar with the fact that an essential, I love that word, essential. How many of you are familiar with the fact that an essential dental benefit for children does not mean that every child has to have it? Are you aware of that? Because there are other sections of the law. And so if you walk out of an exchange and you do not purchase dental coverage for your kid, there's no penalty. And if there's no penalty, some could claim that therefore there's no essential benefit. There is an essential benefit. It says essential. Essential is what it meant. And so there's always more work to do to right those kinds of wrongs that are just happenstance in the policymaking process. So you see private coverage stayed pretty steady, dropped a little bit. Uninsured dropped dramatically, but that big red line of increased public coverage, so that at some point in time, about 50% of kids are covered in public coverage at some point during the year. And this has gotten the attention of the pediatric dental community, because if half of the source of your potential population is in public coverage, you better start paying attention to public coverage. But still, that difference, that argument that we started with, that there was this disparity between medical coverage and dental coverage, that has persisted. It was about half as many kids lacked medical coverage as dental coverage when we started in 1997. By 2016, it was still half, but so much better. I mean, it dropped dramatically. The number of uninsured kids dropped dramatically, but still we're fighting that battle of equity with overall health care. And what happened to dental visits? Well, coverage climbed, and with coverage, people sought more dental visits. And we've highlighted that 50% line there because for the first time in 2016, more than half of kids in Medicaid secured a dental visit for the very first time. Still, pretty profound disparities between kids in Medicaid accessing dental services and all children. The disparity is even greater. I couldn't find the statistic that takes the Medicaid kids out of all children. If I'd been able to subtract them, you would have seen an even bigger disparity. But certainly much better than it had been. And this is a slide that I think Marco showed yesterday, that there has been a steady increase in dental services by Medicaid kids in the orange, and a relatively slower increase in the privately insured kids, and the gap closing. So we're starting to get closer to equity. Okay, every policy and every legislation begins with a problem. The problem was inequities. The policy was, let's get these kids financial access to care, which we figured was a step toward improving oral health. The policy was secured. More children got covered. Financial access was assured. More dental care was delivered. But was oral health better? So we had to start someplace, but we never lost our focus on what we're trying to accomplish. Publication from Health Affairs, most U.S. children today have public or private dental health insurance, yet oral health among publicly insured kids remains a policy concern. Dental care is not the policy concern now. Oral health is the policy concern. The disparities continue. When you ask families if their kids have a dental problem in the last year, you have more low-income kids being reported to have a dental problem than all children. And that was pretty much the same back then as it is now. And similarly, health disparities. Stair step, absolutely predictable by level of income. So, need new policies. Now, what are the policies we're looking at? Well, first, don't let go of what we've secured. Hold on to it tight, make it stay. Number two, further integration of medical and dental. That's the only way we're going to address that disparity between medical and dental. Thirdly, stop thinking about dental care as the best avenue to oral health and start thinking about social determinants, behavioral determinants, environmental determinants, maybe even in our lifetimes, genetic determinants. Let's see if we can't address the things that put kids into risk for disease in the first place. And then consider the 2-gen approach. Really think hard about what difference it makes that the kids live in families. Here's some statistics for you. Despite that tremendous increase in use of dental services and coverage, a study that we recently completed showed that 26% of parents, 1 in 4 parent of a child in Medicaid, doesn't know the kid has dental coverage. Isn't that astounding? And why is that? Because people are so acclimated to having your medical insurance separate from your dental insurance that if your kid has Medicaid medical insurance, why would you think that they have Medicaid dental insurance? 26% don't know that. If the parent has no coverage at all, the child is at 7 times the risk of having no coverage. If the parent didn't use dental services in the last year, the kid was at double the risk, even if they had good insurance. If the parent deferred care due to cost, the child is at 10 times the risk of having care deferred due to cost, even if they have good coverage. So we have to really start thinking differently about kids and their families. And then we need to start rewarding dentists for improving health, not just doing procedures. So there's lots and lots and lots more work to do, but the first bite of the apple was getting the kids covered. That did result in more dental care. Now we need to change the nature of dental care so that we improve oral health.